Capsular contracture is also known as hardening. What happens is the body makes a membrane around the implant, and instead of that membrane staying thin, smooth, and pliable, it thickens and it tightens. As something tightens, it becomes more round, it becomes more hard, it pulls up a little bit and creates a shelf. That's the classic sequence that happens with capsular contracture. It's funny because patients often say, my implants got hard. And I understand why someone would think their implants got hard. But in actuality, the implant itself hasn't changed in its physical characteristics at all. The implant is still soft. It's just that the patient's tissue has thickened and tightened. And that combination of the tightening tissue on the patient is what makes, over the fixed implant, it's that combination of the tightening tissue over the implant that makes everything seem hard. This used to be a real vexing problem. Capsular contracture was rampant in the 80s and early 90s. But right now, though we see it, we don't see it as often. I think the reasons are that our surgical technique is better, our surgical planning is better, and I think that they're making the implants better than they used to. They're using shells that allow less diffusion of silicone, and by doing that, there's less inflammation. You see, capsular contracture is caused by inflammation, irritation. Now, many things can cause that irritation. It can be talcum on the gloves, it can be bacteria, it can be blood left behind at the time of the first operation. So when it comes to capsular contracture, what my biggest assessment is to decide, can I do something different than the last doctor? Because if plan B is the same as plan A, you shouldn't expect a different outcome than the first time. So I'm always looking for something different to do. Now, with capsular contracture, there are a number of things that we can do different, and let me tell you what they are. The first is the incision. There's very good evidence that capsular contracture is highly related to bacteria contaminating the surface of the implant. Not enough bacteria to really give you an infection, but enough bacteria to cause a little bit of inflammation, and that inflammation creates hardening. The breast implant gets in contact with bacteria with the nipple incision. Because as you cut through the nipple incision and then push the implant through the mound of the breast, the implant is crossing into bacteria that are within the breast. So, the first thing that we can do is avoid the nipple incision to reduce capsular contracture. The second is that we can remove all of the scar tissue, all of the capsule. I sometimes see patients who've had earlier treatment of capsular contracture, and the doctor didn't remove all of the capsule. There's very good published data that says that you need to remove all of the capsule, not just part of it, if you want to maximally increase your chances of reducing capsular contracture. The next thing is the surgical technique. Surgical technique should be very precise and very bloodless. We know that blood around the implant can create inflammation leading to capsular contracture. The next thing is that we usually drain. We put a little silicone tube in to remove fluid after removing all the scar tissue. Even if the surgery is done perfectly bloodlessly, there's still some weeping of blood and serum around the implant, and we want to evacuate that through a little tube brought out either through the side of the breast or through the armpit. Another important factor in reducing capsular contracture is antibiotic irrigation during surgery of antibiotics that are very potent for the kind of bacteria that are found in association with capsular contracture. Also important is that we give patients antibiotics in their IV and by mouth afterwards to reduce the load of bacteria in their body. And finally, by doing a very gentle surgery with very little bleeding, it allows the patients to move early. You know, when surgery was more bloody in the past, we would wrap patients and bind them stiff into place, and the implants would kind of just sit there. And then you take this wrap off, and the implants were kind of just stuck into position. So we want to do the surgery gently enough so that patients can move early. There's no definitive treatment for capsular contracture. Capsular contracture still recurs, depends on the study, 15-20% of the time after the first time someone has capsular contracture. But when all of these steps are followed, capsular contracture can be treated extremely effectively with a very low likelihood of recurrence.